I would like to start talking about tests in rheumatology. This is another big part of our evaluation of rheumatologic patients. So test in rheumatology, let's start off with talking about a joint aspiration. This is a big deal. So always a morning report and always at rounds, you know, the residents always tell us, you know, we didn't do a joint aspiration because we think we got the diagnosis otherwise. So the question comes, when do we do a joint aspiration? And let me tell you, for the boards and for the clinical practice, the answer is always, always when you're concerned about septic arthritis. Always. There's no reason in acute monoarthritis not to do a joint aspiration. There may be some reasons, like if you think the patient has cellulitis on top of that, yes, you're careful about that because you don't want to go into the joint, right? And now you got septic joint because the patient had cellulitis on top of that. That's one of the few contraindications. And the other one is bleeding diathesis. If the patient is over, you know, anticoagulated, his INR is elevated, he's on, you know, tons of Coumadin, or he's got some kind of other bleeding diathesis, well, you want to be careful about tapping a joint. But please, in monoarticular arthritis, in acute monoarticular arthritis, because that is the case that you're thinking about septic arthritis, you need to rule that out. And because septic arthritis, if it's misdiagnosed, the patient, because of the inflammation, will get joint erosion sometimes almost in a day. So this guy has a septic joint in the knee. In a day or so, you'll get erosions, you get destruction of the joint. The guy can't walk. So here's a young guy now, can't walk at all. So you have to do a joint aspiration to look for a septic joint and treat it, always. So they may ask us a question about that. This is a very important clinical point. The second thing along this line is people get confused on what tests we get. They're very simple. We don't get any, you know, weird tests. We don't get any, stuff that we don't need. There's only really 4 tests that we ask for from the joint aspirate. So the mnemonic is the 3 C's and the gram stain. The 3 C's stand for white cells, culture, crystals, and the gram stain. That is all. No viscosity, nothing else, no glucose level, nothing like that. All that stuff is useless. Only the 3 C's, the cells, the white cells, that's probably the single most important test, the white cells, because you could stratify that patient based on the white cells. The culture is important if you could get it. The crystals, that's also very, very important. And the gram stain, that's all. And what do we do with all this stuff? Well, we're able to stratify the effusion and develop a differential diagnosis, right? So for example, if the patient had just osteoarthritis, right, the white cells would be less than 2,000, and the crystals and the cultures and everything else would be negative. Now you say, wait a second, but this guy came in with acute monoarthritis, right? Why would he have DJD? I don't know. It's rare that somebody with osteoarthritis comes in with acute monoarthritis from DJD, from osteoarthritis. But if I find less than 2,000 cells, I think about non-inflammatory conditions like DJD or traumatic injury or something like that, you know, something that is non-inflammatory. And then I give him some NSAIDs and I don't do anything more about it. If I find between 5,000 and 50,000 white cells, then I start to think about inflammatory processes like rheumatoid arthritis, lupus, and then the most important thing, because remember, the most important thing here is evaluating people with monoarthritis. That's the differential diagnosis that you could get into trouble with, is gout and pseudo-gout. CPPD, calcium pyrophosphate deposition, right here is pseudo-gout. CPPD is pseudo-gout. These people usually have between 5,000 and 50,000 white cells. And then for gout and pseudo-gout, what do we find? We find the needle-shaped or the rhomboid crystals. The needle-shaped crystals are the uric acid crystals. They're negative birefringent, and the rhomboid crystals are positive birefringent. They hexagonal, octagonal rhomboid crystals. Now I'm focusing mainly on gout and pseudo-gout, because the patient with rheumatoid arthritis who has polyarticular symmetric arthritis, I'm not really worried about arthritis in this person. I'm worried about the monoarticular arthritis that may be septic. So that's why I'm focusing. I want you to focus on these diseases. And then the third one, the third big one, is septic arthritis, right here. These patients generally have over 50,000 white cells. Now here's the thing. The crystals are usually negative in these cases, but the problem is that my gram stain and my culture is also usually negative. That's the problem. So basically, when I have septic arthritis, I can't wait for the culture, I can't wait for the gram stain, because 2/3 of the time it's negative, especially with gonococcal arthritis. The load, the bacterial load in the joints is very small. So the gram stain is usually negative, the culture is usually negative. Sometimes if you have staphylococcal septic arthritis, because that's more, the load is higher, sometimes the gram stain, it's more common to get the gram stain positive in the culture there, but most of the time, even then, it's still negative. So then how do I make the diagnosis of septic arthritis? Here it is. I find over 50,000 white cells in the aspirate. I don't find any crystals, so I say this can't be crystal-induced arthropathy, and I say this is septic arthritis until proven otherwise. I'll wait for the culture and the gram stain and see what it shows, but I'm going to treat this guy for septic arthritis, because it may be that the gram stain and the culture will be negative, and I'm going to probably have to presume this is septic arthritis and treat for the most common organisms. So the aspiration of a joint, especially in monoarthritis, is one of the most fundamental clinical assets you have to basically differentiating between an inflammatory process like gout and pseudo-gout versus a devastating process like septic arthritis, and even sometimes, you know, a rare presentation of something that is like a traumatic or an osteoarthritic joint. A couple more tests in rheumatology. We want to talk about the anti-nuclear antibodies. Now, the anti-nuclear antibodies are, we hear a lot about them. We hear a lot about them in the workup of lupus patients, of other rheumatic diseases like Sjogren's, like systemic sclerosis, and so forth. These are antibodies against nuclear structures, structures within the nucleus, and they're very common in diseases like lupus. You know, we always tend to think it's, you know, lupus, we always think about it, but they're common in other things like Sjogren's and scleroderma and a lot of other diseases. But here's the problem that I want you to know. Anti-nuclear antibodies could be seen in normal patients. Depending on the population you look at, anywhere from 5 to 7 to 10% of the population may have anti-nuclear antibodies positive. So the only way that you could say these are significant is to have the right clinical picture plus the positive antibodies. This is very important. So don't get anti-nuclear antibodies for routine tests on routine studies. They're not done routinely. They're done in the context of, I think this patient may have a rheumatic disease like lupus or Sjogren's, and I'm getting the antibodies to help me out with this and point towards this disease. I don't get them routinely. I don't screen for lupus. I don't screen for any of these diseases. If somebody did that and they're positive, and the patient comes to you and says, look, I got positive anti-nuclear antibodies. I've never had a symptom in my life. What does this all mean? The answer is, it probably means nothing. Why? Because a good percent of the normal patients will have positive anti-nuclear antibodies. When they report to us a positive anti-nuclear antibody, they tell us a couple more things. They tell us about the pattern of the anti-nuclear antibody. So you hear speckled pattern, rim pattern, nucleolar pattern. Most of the times things like speckled pattern don't usually mean anything. sometimes the rim pattern, RIM, the rim pattern, is associated with systemic lupus erythematosus. But generally, the pattern itself is non-diagnostic of anything. Then, as a third part to this test, they tell us that some of the subsets of these anti-nuclear antibodies are positive or negative and so forth. And these subsets of antibodies may be very specific for some diseases. Now this is important because the double-stranded DNA antibodies and the anti-SM antibody, the Smith antibodies, are very specific for patients with lupus. If I see somebody with any type of symptoms, arthritic symptoms, or any type of symptoms consistent with some rheumatologic disease, and either the double-stranded DNA or the Smith antibodies are positive, these one right here, then I say to myself, these are very specific for lupus, and this patient likely has lupus. They're very specific for lupus. And then some other subsets that we're going to talk about on the table in a little bit, like antihistone antibodies. Those are very specific for things like drug-induced lupus. So overall, anti-nuclear antibodies in the right context are very good. They tell us about certain rheumatologic disease. Some of the subsets are very specific. The patterns are non-specific. And then the thing I want to tell you is, especially when you're looking for lupus, almost 100% of these people have some anti-nuclear antibody positive. So I could say, if somebody has lupus, if I think they have lupus, if I find the anti-nuclear antibody negative, I'm going to say no. This patient doesn't likely have lupus now because all of these patients likely have anti-nuclear antibodies positive. It is a very sensitive test to diagnose lupus, and we're going to talk about that again and again today. Talking a little bit more specifically about the patterns and the specific antibodies, we're going to go to the two tables about the ANA patterns, and this is what I was just referring to. For example, we see the peripheral, the rim pattern. Sometimes these are all patterns now, right, that could be reported to us, and this is sometimes associated with lupus. It's commonly associated with lupus, I should say, where you see the diffuse and speckled that I was referring to, really nonspecific. It doesn't mean anything. These are the ones that we commonly find in normal people. And then the one that's important, the other one that's important in terms of pattern, is the anti-centromere. This is important because it's associated with this limited form of scleroderma called CREST syndrome. We're going to talk about this a little bit later, but it's nice to know here. And then sometimes the nucleolar pattern is associated with systemic sclerosis. But generally, the patterns itself are not specific for everything, for anything. It's just sometimes they point towards certain diseases that we have to look for. The specific antibodies that I was talking to you about is a little bit different. So the first two I want you to know is the two that are associated with lupus. Here they are, the anti-double-strand DNA antibodies and the anti-Smith antibodies. Both of those are seen in lupus, and you could see the percent here. We don't see them in all lupus patients, so they're not sensitive. And we only see the anti-Smith antibody in about 30% of the case with lupus, so 70% don't have it. But when they have it, when it's positive, it is very specific for this disease. So if I don't see it, it doesn't mean that this patient doesn't have lupus, but when I see it, 99% of the time, this patient has lupus. Now, the double-stranded DNA you're going to hear more about later today when we speak about lupus is very interesting because it gives us two other things if it's positive. It tells us that this patient will likely have lupus nephritis. That's a big cause of morbidity and mortality in lupus patients, lupus nephritis. And the people that have the anti-double-stranded antibody, those will likely get lupus nephritis. And in the patients that it's elevated, it also sometimes is an indicator for disease activity. And what do I mean by that? That we know sometimes patients with lupus come in and they complain of different things, and we're not sure if this is a lupus flare or they just got a viral syndrome and they just don't feel well. And so we need indices of disease activity, and this is one of them. An increase in the level of double-stranded DNA antibodies would tell me somebody coming in with complaints that already has been diagnosed with lupus will tell me that he or she is likely having a lupus flare. So the double-stranded DNA points to the disease. It tells us, yes, this is likely lupus. Number two, it tells us that this patient will have lupus nephritis. And number three, it helps us to diagnose flares of the disease because it goes up with the flares, and then in remission it goes down basically to almost normal levels. Antihistone antibody we talked about is drug-induced lupus 95% of the time, and then you're going to hear about these other antibodies called anti-Rho and anti-La antibodies. They're sometimes also referred to SSA and SSB. The SSA stands for Sjogren's syndrome A antibodies, and the B stands for Sjogren's syndrome B antibodies. That's the La, because they were first described in patients with Sjogren's syndrome. Both of these are seen in Sjogren's, and they're pretty specific for Sjogren's. We also see anti-Rho antibodies as a part of another syndrome that you have to know. You have to know the syndrome for the board. This is called neonatal lupus, where these patients with systemic lupus erythematosus have anti-Rho antibodies, and these antibodies cross the placenta and they affect the neonate. They cause neonatal lupus, and they cause congenital heart block. That's the big problem. So you have to tell the doctor there, listen, this patient has anti-Rho antibodies. You got to watch that neonate. They may have a congenital heart block. You have to pace the kid, unless something happens to them. The anti-centromere antibodies are associated with CREST syndrome. We talked about this in the pattern, right? And the anti-RNP antibodies are sometimes seen in these diseases called connective tissue diseases or mixed connective tissue diseases. I want you to know specifically the anti-double-stranded DNA, the anti-Smith antibody, the anti-histone is very important, and the anti-Rho, anti-La, and anti-centromere are also very important, and we'll be talking about them again when we talk about the specific diseases. So to summarize this thing about the anti-nuclear antibodies, how do we use these tests in the clinical setting? So take a patient that I'm thinking about lupus, right? And they tell me the test for anti-nuclear antibodies is negative, right? Here it is. I'm thinking some young woman comes in with these joint complaints and some, other stuff that she's got, and all of a sudden I get the anti-nuclear antibody test is negative. So they don't give me any specific antibodies because the test is negative. I don't get any patterns back. They just say it's negative. What does that mean? Well, remember I told you all patients with lupus have anti-nuclear antibodies positive. They may not have some specific antibody positive, but they have some sort of anti-nuclear antibody positive. So right away when I see a negative test in somebody that I think has lupus, I say, this patient has something else. They don't have lupus because almost 100% of these patients have anti-nuclear antibodies positive. In the true clinical setting, I'll tell you the truth. The truth is 97% of them have anti-nuclear antibodies positive. But for your purpose, it's 100% to answer questions on the boards. So for our test purposes, 100% of the patients with lupus on the boards will have anti-nuclear antibodies positive, some anti-nuclear antibody positive. If they don't, they likely don't have lupus. In fact, they don't have lupus. A positive test, on the other hand, a positive test has to be interpreted in the right clinical setting, in the right clinical context. If a positive test occurs in an otherwise healthy woman, I don't know what to do with that. It's likely a false positive. It's, the 5–10% of the normal population. If a positive test occurs in somebody with arthritis, right, rash in their face, stuff like that, that positive test is likely real positive. This patient likely has lupus. If a patient I find with clinical symptoms, I get a positive test and they tell me the double-stranded DNA is positive or the Smith antibody is positive, I'm pretty sure that patient has lupus because remember I told you those two antibodies are very specific for lupus. So think about those 3-4 things that we said, and manage the patients accordingly when they give us questions about anti-nuclear antibodies. A couple more rheumatologic tests. The other common one that we do in clinical medicine is a rheumatoid factor, and this is a test that is usually positive in rheumatoid arthritis. But there is about 20%, they say, maybe 30%, that have typical rheumatoid arthritis, and the rheumatoid factor could be negative, and this is sometimes referred to as rheumatoid factor negative rheumatoid arthritis, right? So patients can have rheumatoid arthritis with a negative rheumatoid factor, but it's usually positive, 2/3, 80% of the cases. So we could still make the diagnosis of rheumatoid arthritis without the rheumatoid factor. That's what I'm really trying to tell you, as long as they have all the other stuff. If a patient with rheumatoid arthritis has a very high rheumatoid factor, 1 to 1,000, 1 to 2,000, 1 to 1,800, very high, it renders a poor prognosis. It tells you that this is going to be a very aggressive disease. This patient will have really aggressive disease, early erosions, right? You know, a lot of flares. So think about that, because you need to treat that patient aggressively from the beginning. So a rheumatoid factor may help me in the diagnosis of rheumatoid arthritis. A negative one doesn't, exclude the disease, but if I find a very high rheumatoid factor, that is likely a poor prognosis. I'm going to really start treating that patient aggressively. Also, I don't want to mix up people, but rheumatoid factors are positive in other diseases. Like, for example, we could find them in osteomyelitis, right? We could find them in tuberculosis. We could find them in people with other chronic diseases like endocarditis, subacute endocarditis. So if the patient doesn't fit the picture of somebody with rheumatoid arthritis, right? Rheumatoid arthritis means polyarticular symmetric involvement. Think about some other diseases. They try to stump us sometimes with a case of endocarditis, because commonly endocarditis has a positive rheumatoid factor. Think about that. A rheumatoid factor is basically an antibody against the FC portion of another antibody. That's all a rheumatoid factor is. IgM against IgG, IgG against IgM, and so forth. Anti-nuclear cytoplasmic antibodies, or ANCA antibodies, is a third test that we need to know for rheumatology. And really all we need to know, we're going to talk about these tests a little bit more when we talk about the specific disease. These tests have come out, in the last 10 to 12 years, but people are using them a lot. And I want you to remember an association with really only one disease, and that disease is Wegener's granulomatosis. Wegener's vasculitis is associated with C. ANCAs, with the cytoplasmic type. Nothing else. For your purposes here, I've put that yes, with polyarteritis nodosa, with inflammatory bowel disease, with some of the other vasculitides, you could see a positive P. ANCA in them, but it's totally nonspecific. The only one that really has a good correlation is Wegener's and C. ANCA. It's not diagnostic of Wegener's. The diagnosis is made on a biopsy. We'll see that later. But it points towards Wegener's. So if they ask you, this patient has arthritis, has nephritis, positive C. ANCA, what does the patient likely have? The answer is Wegener's disease. What do I have to do? I have to get a biopsy to confirm that. So please be careful of that. And then we want to talk a little bit about the antiphospholipid antibodies. Now this is the lupus anticoagulant I was talking about when I talked about thromboembolic disease in the pulmonary section. Now this is a very important syndrome. We're going to get questions asked about this. They have different names to them, but they go under antiphospholipid antibody syndrome. That's really the whole syndrome. And you may hear the terminology lupus anticoagulant. This refers to the elevated PTT that is seen in some of these people. It was called lupus anticoagulant because it was first noted in a patient that had systemic lupus. And then you may hear the term anticardiolipin antibodies, right? Because some of these patients have a false positive VDRL or RPR, so they have antibodies to cardiolipin. So just based on these two things that I just talked to you about, these patients will have an increased PTT and a false positive VDRL or RPR. Now, where people get mixed up is they hear the elevated PTT, right? And an elevated PTT usually means people that have bleeding diathesis, but not these patients. This is basically a lab phenomenon. It happens in the lab because we use phospholipid to run the PTT. And these patients have antibodies to phospholipid. They inhibit the phospholipid, so the PTT is elevated. It's a lab phenomenon only. These patients really have hypercoagulable state. This hypercoagulable state, we're not sure why they have hypercoagulable state. It's not due to the phospholipid antibodies. It's not due to the cardiolipin antibodies. These are just markers for the disease. So they're hypercoagulable. They have clotting. How do they present? With venous and arterial thrombosis. Now, I've underlined arterial thrombosis here. This is very important because this is one of the few hypercoagulable states that may present with arterial thrombosis. Most of the other ones have just venous thrombosis. So please, please remember that. Most common presentation that we see in clinical practice is a woman that comes in and has multiple spontaneous abortion and is otherwise healthy. They don't all have lupus. They're, in fact, mostly healthy. This patient, check for the antiphospholipid antibodies. Check a PTT, check a VDRL, and you could directly measure the antiphospholipid antibodies. You could run a test that measures the antiphospholipid antibodies. If the patients have had multiple spontaneous abortions or they're symptomatic, we have to anticoagulate them. If the patient has just had spontaneous abortions, then we anticoagulate them only through pregnancy, so they're able to deliver a normal pregnancy. If they have thrombosis outside of the pregnancy, like DVTs outside of the pregnancy, or arterial thrombosis or pulmonary embolism outside the pregnancy, then we have to anticoagulate them lifelong, forever, because they have a risk of throwing thrombosis again. So this is very important. This is a very important syndrome. We are likely going to have questions on this topic. So that concludes the tests